Hello, everyone, and welcome to today's webinar. Welcome back, How to Address the Decline in HPV Vaccination and Cervical Screening Rates. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Roche Diagnostics. To learn more, visit roche.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speakers. David Pride, MD, Ph.D., Professor of Pathology, Director of Molecular Microbiology, Director of Microbiology, University of California, San Diego, and William Calo, Ph.D., J.D., MPH, Assistant Professor in the Department of Public Health Sciences at the Penn State College of Medicine. Dr. Pride, Dr. Calo, you may now begin your presentation.
Hello, this is William Calo, Assistant Professor of Public Health Sciences at the Penn State College of Medicine in Hershey, Pennsylvania. The title of my talk is The Past, Present, and Future of Cervical Cancer Screening, the Importance of HPV Vaccination. The objective of my lectures are present information about cervical cancer and HPV vaccine disparities in the US, describe vaccine hesitancy, and discuss best practices for HPV vaccination and cervical cancer screening. I want to start saying and describing how common is HPV. There are more than 100 different HPV types that have been identified, and 3 out of 4 sexually transmitted infections, or STIs, in the US are from HPV. As we speak, there are over 80 million men and women in the US who are currently infected with one or more strains or types of this virus. And 70% of all people will be infected with HPV at some point in their life. So in addition to genital warts, HPV plays a high burden on cancer. And as you can see from this figure, every year in the US, HPV causes more than 36,000 cancers. And specifically, there are six of them. But I want to point out to cervical cancer. In the US, HPV causes almost 11,000 cervical cancer among women. And although oropharyngeal cancer are the most common cancer in the US caused by HPV, when you break down the cancer types per gender, cervical cancer is the most common cancer for a single gender. You can see that it is over 100 cases per year compared to oropharyngeal cancer. The good news is that cervical cancer incidence and mortality rates have decreased by more than 50% over the past 4 decades. The bad news is that not all racial ethnic minority groups in the US are experiencing this benefit. And you can see from this figure, the blue bars reflects or demonstrate incidence rates, and the red bars shows rates for mortality. And it is very consistent, as you can see in this figure, that for 3 specific minority groups, non-Hispanic Black females, American Indian, Alaska Native females, and Hispanic or Latina, they experiencing higher rates of both mortality and incidence when compared to non-Hispanic whites in the US. The good news is that we have a vaccine that is safe and effective to prevent HPV infection and HPV cancer, and that's the HPV vaccine. And the vaccine is recommended by the CDC, by trusted national medical organizations like the American Academy of Family Physicians and the American Academy of Pediatrics. In the US, the HPV vaccine is recommended for all adolescents ages 11 or 12, but the vaccine can be given as soon as age 9. One of the benefits of receiving the vaccine at younger ages is that at younger adolescents, they have a stronger immune response. And also, we want to give the vaccine before they are exposed to the virus. It's equally important that all adolescents receive the HPV vaccine, including both boys and girls and all adolescents, regardless their racial and ethnic background. Another good news is that if they receive vaccination at early ages, they only need 2 doses. If they receive vaccination, they initiate vaccination at age 15 or later, they would require 3 doses instead of 2. HPV has proven to be effective in decreasing cervical HPV infections and cervical precancer lesions in the U.S. among younger females. And you can see in this figure, the top portion of this figure is just showing information about decreases over time, actually over the last decade, for younger females, 71% decrease in terms of cervical HPV infection and a 59% decrease for cervical precancer lesions among young females here in the US. When we compare data about those who are vaccinated and unvaccinated, we have very good data for oral HPV infections. And the data is also promising. It's very good. It's just showing that those people who have received the vaccine or have completed the vaccine series, depending on 2 or 3 doses, depending on their age, they have 80% lower HPV infections when compared to those who have not started HPV vaccination. So here in the US, we're seeing some promising findings about how HPV vaccine at the population level is helping decrease cervical HPV infections and cervical precancer lesions among women. Very promising as well, not only in the US, but other countries have a very aggressive target or goal to eliminate cervical cancer. And this is the case of Australia. And by eliminating cervical cancer, what they mean is they want cervical cancer to become a rare disease. And I want you to read the information at the bottom of this news report from 2018, just saying Australia will become the first country to effectively eliminate cervical cancer if 2 things happen: if vaccination and screening rates are maintained. And I think very, very important, because both things go hand by hand in terms of eliminating or diminishing cervical cancer, not only in Australia and other countries, but also here in the US. And those 2 things are cervical cancer screening and HPV vaccination. Here in the US, not everybody is getting the vaccine as recommended. We're seeing this data here for adolescents aged 13 to 17. You can see on the left side of this figure, this is the percentage of kids vaccinated. I'm running from 0 to 100%. That's the graph you can see there. And also at the bottom of the graph, you can see the year from 2006 to 2019. There are 3 vaccines recommended for adolescents in the US, and those vaccine protects. Those vaccines are the ones showing in this figure. At the top of the figure, you see a blue solid line. That line represents vaccination rates for Tdap in the US. The next line is very close to that first line. The second line is the vaccine to protect against meningitis. And as you can see, in 2019, both vaccines reach almost a 90% of vaccination rate in the country for these adolescents. So this is pretty good, because the national goal is 80% of vaccination. However, if you go a little bit lower in this figure, the third line, kind of in the middle, is HPV up-to-date vaccination for HPV. And I mentioned before, depending on your age, you will require 2 or 3 doses of the vaccine. So up to date is a measure combining both if they need 2 or 3 doses. So you can see in 2019, vaccination rates for HPV were a little bit over 60%. That means 2 things. Number one, that we're 20% points below the national goal of 80%, and also that compared to Tdap and meningitis vaccines, HPV is 30% points lower than the other 2 vaccines. So meaning that parents are going to see doctors but they are not accepting HPV vaccine, despite they're accepting the over 2 vaccines required for school. So this means that there's many opportunities to increase HPV vaccination here in the US. The reason for this is vaccine hesitancy. And you can read the definition of vaccine hesitancy here from the WHO, but it's quite important that we understand the spectrum of vaccine hesitancy. There's, I think we have simplified this conversation in the US and other countries about if you're anti-vaccine or pro-vaccine. But vaccines vaccine hesitancy has changed over time, and COVID-19 has changed the way that we think about hesitancy and refusal. And it's important to understand that there's no side versus the other. Parents and adults, they have a lot of attitudes that are not in those different extremes. There are people with honest questions and concerns, and because they're not sure about getting one vaccine, because they have those concerns, you cannot classify in one way or the other. And I will show you some examples of that in a moment. I really like this. This table is a paper published almost 10 years ago. And it showed what I was explaining to you, the categorization of attitudes toward vaccines, or vaccine confidence and hesitancy in this spectrum, or these 5 categories. The most important thing here is just to say, as you can see at the bottom of this table, refusers. Usually they're between 3 to 5%. People who actively reject vaccines, all vaccines. There's no information that can convince these people. The good news is that almost 97% of the population, they will accept vaccines depending their communications. And let me go for each one of these different buckets or type of patterns in terms of the vaccine attitudes, what they mean or they believe about vaccines, and what kind of interventions you can deliver to reach or target each one of these specific type of patterns. So let's start with the first two groups: the immunization advocates and the go alone to get along type of pattern. So the first one, they actively seek vaccinations. They demand vaccination. They go to clinic visits knowing I want to get the vaccine for my children. And the second group of pattern, what is called the go alone to get along, they agree that vaccines are safe. They're not going to clinic visits knowing that their child is due for a particular vaccine that date. But if the vaccine is recommended by their doctors or medical team, they will follow that advice and they will get the vaccine. So the important thing with these two type of patterns is that we have to deliver interventions that do not raise concerns that do not already exist among these two groups. So the most important thing is, again, is just announce that the vaccine is due and let them parents know that child that age are due for some vaccines, and they will get the vaccine. Okay, with some of them, with that small reminder, some of them they're actively seek the vaccine. So you don't have any problem with this type of parents in terms of their communication needs. Then we can move to the third category, and as you can see, there's another 25% of parents in this group here. And so what we call the cautious acceptor. These parents have some concerns about vaccines, but this is the good news. They will vaccinate. They will get the vaccine after their questions or concerns are answered in a satisfactory way. So that means that although these people have some questions, they will accept the vaccine if you, as a clinician, can deliver effective messages to them. Then we are going to the last two groups in these categories, including fence sitters. These people have serious concerns about vaccines. They're very uncertain in their vaccine decisions. They're also very important to target in vaccine communication, especially during clinical encounters. But I'll tell you two things about this type of patterns. You have to be prepared to engage in longer discussions or conversations with them, different from the cautious acceptor, that a brief message would be enough to convince them. With this type of pattern, the fence sitter, you may need to expand your communication with them, give more information, and sometimes has to happen outside the clinic visit. So you have to be ready to continue this conversation in future visits. It's okay that some of them will not get the vaccine, but the very important thing is to remind yourself in the chart that this particular parent or adult reject vaccination, the reasons why, and then you address the same issue in future visits. And lastly, we have the refusers I mentioned. Overall, depending on the country, you will see something between 3 to 5%. With the pandemic, the number have increased slightly. Yeah, that's something that we are aware. This is the most challenging type of parents or adults to reach. The most important thing here is that they will not get the vaccine. They will actively reject all vaccines. But it's important that you build trust. These people have a large distrust in the scientific community and the medical community at all. So it's important that over time you continue building this trust. You don't know 5-10 years down the road, they will get vaccines for themselves or maybe vaccines for their own children. So again, I want to recap something very important that I mentioned. It's quite important that we depolarize these conversations about pro versus anti-vaccination positions, because as I show you in the prior slides, yes, there are two extremes of people who actively seek vaccines and people who actively reject vaccines, but they're in the middle, sandwiched in the middle. There's almost 70% of parents who have some concerns or need some advice or guidance to get this vaccine, HPV and other vaccines overall. It's equally important that you identify strategies to address questions and concerns without judgment. That you tell parents that you are listening to their concerns, and then you provide effective messages. For some of these parents, short messages will work pretty well, but some other parents, you will need to provide more information as you understand where those questions and concerns are coming from. And lastly, it is important that you understand and identify what best practices exist, so you can approach parents where they are in terms of their communication needs. And I'll show you two examples about effective and evidence-based practices that I have been using in my prior research. One at the clinic setting is called the announcement approach, and the second one is through social media and health promotion campaigns. So let's start with the one that I use in clinic setting. It's called the announcement approach. The announcement approach basically says two things. We should start announcing very briefly that the child is due for HPV vaccine and other vaccines due at that age. So basically you do three things when you do this announcement. You know the child's age. You announce that children this age are due for vaccine that prevents several diseases, including HPV cancers. And you say that the child will get the vaccine today or at the end of that visit. And an example of how this type of announcement will look like is something like this. Now that Sophie is 11, she is due for 3 vaccines. Today, she will get vaccines against meningitis, HPV cancers, and whooping cough. A good number of parents will get the vaccine by just saying a simple 5-second statement like the one that I just mentioned, especially those parents who are in the first two categories that I just described a moment ago. So a good number of them, almost 50% of parents, will get HPV vaccine by just saying something as simple and short as this. However, some parents, as I mentioned, will hesitate, will show some concerns, and that's okay. You have to do 3 things here in this second step. First, you will be connecting with them. You will ask the parent for their main concern, and you're showing the parent that you're listening, something like, oh, can you tell me more about the reason you don't want to get the vaccine today? So in that way, when you move to the next step, the clarify step, you use research tested message to address that specific concern. If the question is about safety or side effects, there's no reason to bring information about sexual activity or vice versa. If the question is about sexual activity, there's no reason to talk about safety or side effects or vaccination guidelines and so on. So because you are just directing the conversation to address the main point to be addressing that communication needs for this parent. And lastly, you cancel. You give a reason. To vaccinate. My team and others, we have been working for the past 7-8 years testing messages that providers can use to address these questions and concerns that parents may have. And we just published a paper with the 7 most common responses based on 7 common questions and concerns that parents may have. And these are starting point conversations. You can use this in your clinic, and then you can elaborate depending if a parent continues showing some distress or is not convinced by the information that you can provide. But as I mentioned, for most parents who show some hesitation or concern, these brief messages will be enough. Okay. The other type of intervention that I want to show you is this one here. And I have been working with many cancer survivors who have been diagnosed with HPV cancers in the past to record, film their stories, and use that in clinical settings. The video that you will show here is from Jeff. Jeff wants his story to be disseminated so other parents learn about what happened to him, so motivate them to get the vaccine. I know this talk is about cervical cancer screening. Most of the videos that I have been developing in the past year focus on oropharyngeal cancer. That's the story that you will hear in a moment. But my team is just working to create similar stories and identify women who would like to share their experience with cervical cancer, so other families with girls can benefit from this type of intervention. So let's listen to Jeff for the next 3 minutes and a half.
I'm Jeff, I'm 63, and grew up in a little town called Boiling Springs, Pennsylvania. I couldn't breathe very well through my right nostril, so I went to the doctor. Actually, I scheduled to go to the doctor, and about 2 days before the appointment, a gland swelled up in my neck about half the size of a golf ball. So I went to the doctor. They looked at it, had me go to get a scan, and then sent me to a specialist, head and neck specialist. And there I was diagnosed with stage 4 HPV cancer, head and neck cancer. So it was multiple places in my neck, in my right nostril, behind the base of skull. After you get your scans, and they do the evaluation, and they determine what kind of treatment you're gonna have. It's pretty much 35 days of radiation and 3 or 4 rounds of chemo. I started at 220 pounds. After it was all said and done, about 4 months later, I was 160 pounds. So I lost 60 pounds during the process. To get the radiation, you have to have a mask made. And it's a wet mask with holes in it. And they put it on your face and neck, and then it molds to your head. And it molds very close, very close. And the reason for that is because when you have the radiation treatment, they want to be very precise. And so this mask, when it dries, you lay on a table and they clip you down onto the table so you can't move. And that's very important. So they try to minimize any damage to good cells. So they want to just focus on the bad cells. It's not a good thing for your caregivers, in this case my wife and daughter, to watch this slow process. It's the sunburned skin, in my case, skin fell off, so it was regrowing new skin, and the mouth burns, and your life changes, especially radiation really affects your swallowing, and it pretty much damages all your salivary glands. So you have dry mouth for the rest of your life, severe dry mouth. You have to drink water or something when you eat, or you can't get it down. It wakes you up about every 2-3 hours. You can't get a full night's sleep. It makes you reevaluate your life. For me, I had a recurrence after 2 years, and it showed up my right lung, so we ended up going to a clinical trial, and I went through that for 2 years. And that I was very fortunate. I had 100% response to that, so I'm, at the moment, cancer-free. If you're considering getting the HPV vaccine, I would recommend it. You really don't want to be treated for this particular cancer.
Again, although this particular story is not about cervical cancer, I want to share that with you because I think it's quite important that we use this type of storytelling intervention to convince parents of adolescents about the dangers of not getting the HPV vaccine, and also mention my team is just identifying women who would like to share similar stories but with cervical cancer in order to develop similar videos to be deployed in our primary care clinics in Pennsylvania. And the video that I just showed to you is going to be is available for free. So if anyone is interested to use that for your clinic or any of your interventions, you're more than free to just send me an email and I'll share that with you without any problem. One last thing is that HPV vaccination have dropped during the pandemic, and but important point, the largest gap is in vaccines primarily given to adolescents, and more particular HPV vaccination fell by 3 to 4 million doses during the COVID-19 pandemic, or equivalent to 25% drop compared to 2019. So I think there's a lot of work that we have to do in order to bring vaccination rates where they were 2-3 years ago. And lastly, the spread of vaccine misinformation makes ongoing vaccine promoting efforts more challenging. So I think it's equally important that interventions like this one that we can deploy in social media are easily available to correct misinformation that is available, and at the same time occupy that space so misinformation is not available and spread widely. So as a takeaway, I want to say cervical cancer screening and HPV vaccination are important for cancer prevention and control, are very important cancer prevention and control tools. And both things need to be used simultaneously if we want to eliminate or eradicate cervical cancer in the US or worldwide. If you're a clinic staff, recommend HPV vaccination using the announcement approach with every single patient that you can see. And be creative using information and technology to educate about cervical cancer screening and HPV vaccination. There are many of the similar stories that I showed you a moment ago that are available through the American Cancer Society among cancer patients that you can use for cervical cancer, breast cancer, and other cancers, as the one that I just showed you a moment ago. I'm going to say thank you so much, and you have my email. If you have any question, we have a Q&A at the very end of this lecture, so feel free to ask me any question or send me an email. Thank you so much.
Thank you so much for your attention. I'm Dr. David Pride. I'm going to talk to you guys today about HPV, or human papillomavirus testing. And I'm going to talk about it a little bit in the context of vaccinations, the risks for acquiring HPV, and in particular, what happened during the pandemic, largely in the year 2020. So as we get started, I want to start with my disclaimers. So first, I have been a consultant for Roche in the past. I currently am a consultant for Cepheid, and I have been a consultant for Hologic, many of whom do perform HPV testing. So the goals for this webinar. So first, I'd like to discuss really the importance of HPV testing. Then we want to provide an overview of the approach that can be taken to HPV testing, with a particular emphasis on identifying high-risk genotypes. Also, who should be tested in terms of both males and females. And then to discuss a little bit about the testing protocols that can be used. We want to put particular emphasis on the impact of the early pandemic in the year 2020 on trends that we saw in HPV testing. And then we want to end up talking a bit more about vaccinations and how the lack that we saw of vaccinations could potentially impact HPV and HPV-associated diseases in the years to come. So what is HPV? So HPV is human papillomavirus. It's a small, non-enveloped DNA virus. It does have the potential to cause long-term infections. Although I think what is probably lesser known is that HPV does have the potential to cause short-term infections that can, in essence, resolve on their own. But when we think about HPV and when we worry about HPV, what we really worry about are those long-term infections. HPV generally is spread through sexual contact. It may also be spread through sustained skin-to-skin contact. And there is the possibility that it could spread via fomites, although that's not believed to be a way in which it commonly is spread. So, for example, HPV is not something you would expect to get if you sat on the toilet and someone, for example, with HPV had sat on that toilet before you. It is the most common sexually transmitted infection in the world. There are over 170 different types of HPV that have been described to date. And HPV is known to cause a couple of different types of diseases. Probably one of the more common things is warts. And while warts can be very unsightly, the warts in general are not what we worry so much with HPV about. What we worry the most about with HPV are the fact that it's associated with several different types of cancers. And those include cervical cancer, oropharyngeal cancer, and other types of squamous cell carcinomas. We've known for many years now that HPV is associated with cervical cancers. And it doesn't matter really what part of the world you look in, most studies basically show the same thing, and that is that the overwhelming majority of cervical cancers are indeed associated with long-term HPV infections. So as I sort of had mentioned, HPV, there are different types that people can get. Types 6 and 11 are very, very commonly associated with the presence of warts. And as I mentioned, while they're unsightly, they're not really what we worry so much about with HPV. What we worry about are the high-risk genotypes, in particular genotypes 16 and 18, although there are many other, at least 14 other high-risk genotypes that many of the HPV tests nowadays do evaluate for. So we know we should be testing for HPV. And the large reason that we want to test for HPV is, one, it's a sexually transmitted infection, and we want to decrease sexually transmitted infections. But of course, it is a strong cause of cervical cancers and other types of cancers as well. And we want to significantly reduce those individuals in our population that get diagnosed with cancers. So as part of HPV testing, you could test both men and women. Unfortunately, with men, there is no routine screening that is recommended. And we'll kind of get to in a second why there is no routine screening. But there is high-risk screening, in particular individuals at risk for throat cancer, or oropharyngeal cancer, as well as anal cancers as well. And in general, screening for those individuals tends to be institution specific. So there isn't really right now any universal guidelines for the screening. Screening in women is probably a bit less complicated in general because of the concern for cervical cancer. There are multiple different ways to screen for cervical cancer. One of the ways can be HPV testing alone, particularly in women aged 30 to 65 who can get an HPV test basically once every 5 years as a screening tool against cervical cancer. As we mentioned, the overwhelming majority of cervical cancers are associated with HPV, so it's a reasonable thing to do. Women may also get cytology from routine pap smears, and in general, when those pap smears are abnormal, oftentimes those women will have HPV testing anyway. So to reduce HPV transmission, and that's one thing in general that's very important to know. So while things like condoms and even gloves during things like sexual contact may be recommended, it's important to know that you can reduce the spread via condoms and gloves, just like you can reduce the spreads of many other sexually transmitted infections. One thing to know in particular about HPV is that while it doesn't typically go through condoms or through gloves, it can go around them. So it's certainly not 100% protection, and that's the one thing to know. It's important, it's useful, but it's certainly not going to protect you 100% against the potential for an HPV infection. So while there's no routine screening recommended for men for HPV, there's plenty of routine screening recommended for women. When it comes to vaccinations against HPV, the absolute recommendation is for vaccinations for both males and females. And the large part is, we talked a bit about cervical cancer, but men can be extraordinary vectors to spread HPV to women. So if you were only vaccinating women against HPV, there would still be plenty of men out there acquiring HPV infections and transmitting those infections to women. So it's important to focus on both men and women when it comes to HPV vaccination. Right now, it's recommended to start vaccinations between ages 9 and 13. There are multiple different HPV vaccinations available, such as the Gardasil 9, which has protection against multiple different types, both low risk and high risk types of HPV. So, for example, we talked about type 6 and 11 being responsible for genital warts. Those are included in the Gardasil vaccine. As we talked about type 16 and 18 being associated with cervical and other types of cancers, and those are included in the vaccine. And it's important to know in those individuals who are vaccinated, you can significantly reduce genital warts by about 90%, as well as associated cancers by about 90% as well. So it's very, very important to administer these HPV vaccines. If someone's already infected with HPV, so for example, say a woman already has a chronic infection with HPV type 16, it's not going to help to get the vaccination at that point, meaning that because the vaccination has HPV type 16, you're not going to, for example, clear that infection just because you get the vaccine. The goal is to prevent that infection. One point, though, that I would make is that you can get multiple different HPV infections, so that there's some potential, if you've got 16, to prevent getting 18 or prevent getting type 33, for example, on top of that 16. So it's not a complete lack of benefit for getting a vaccination in someone who may already have an HPV infection. So the role of the clinical lab is really important in HPV infection. And we don't oftentimes think that much about the clinical lab. And part of that is that the clinical lab doesn't have actual contact with the patients involved in the testing. But I can tell you as a clinical laboratory director, the pandemic really stressed us quite a bit, and not just from a testing for COVID perspective, but also in terms of testing for all these other sexually transmitted infections, such as HPV. It was a struggle to get COVID tests, but what I think a lot of people don't know is it was also a struggle to get the other tests like HPV tests as well. And part of that is that, a lot of companies were shifting their manufacturing to COVID tests and away from a lot of the other types of tests. So those tests were also in short supply. And the one thing that that actually really helped us out quite a bit was the decreased demand. So the fact that, there were stay-at-home orders and people weren't getting tested for a lot of sexually transmitted infections, it's bad for the patient. It really was, because diseases like gonorrhea, chlamydia, and HPV continue to spread through the population. In some ways, it was good for clinical labs, just because, quite frankly, we wouldn't have been able to test all the people in the midst of the SARS-CoV-2 pandemic, because we just simply didn't have enough supplies to be able to do so. So we were constantly faced with the question of who do we prioritize, how do we prioritize testing? And it's not just something that happened to us, it happened really all across the United States. So the pandemic, particularly in the year 2020, had significant impact on sexually transmitted infections. It did on HPV, it did on gonorrhea, it did on syphilis, it did on chlamydia as well. What you guys are looking at really is the percentage of tests compared to the previous year, particularly positive tests. And we can see they're just way down in the year 2020. And all of that really is due to change in some behaviors, in particular change in going to see doctors during the earlier parts of the pandemic. So we tracked our testing at our institution during the pandemic. We saw significant decreases in volumes of many of our tests across the year 2020, particularly when it came to sexually transmitted infections. We saw fewer chlamydia gonorrhea tests. We saw fewer HIV tests. We saw fewer hepatitis B. We saw fewer syphilis tests. We now have basically returned to baseline, or to what we expect to be, but there was a significant impact in the year 2020, and it's likely an impact that the patient populations will be observing for years to come. In particular for HPV, according to our sort of charting, we expected to see about 8,800 HPV tests in the year 2020. We only saw 7,400 HPV tests. That is a significant decline. We didn't see any declines in the positivity rates. We just saw declines in the number of people who are tested. So to some extent, HPV was likely spreading undiagnosed in our patient population during that time period. And that's just something that we have to deal with on the back end now. While our volumes were way down, the volumes of screening for cancers in California in general were down by about 80%. We believe are a harbinger for the rest of the United States, meaning that testing was down all across the board, particularly when it comes to HPV, particularly when it comes to cancer screening as well. And most of that's due to the pandemic, the limitations on supply, as well as just the decreased doctor visits that we saw during that time period. So again, we saw testing impacted really across the board, and it was not widely publicized that we had such impacts or decreases in our testing potential during that time. And we kind of thank goodness that it wasn't widely publicized, because we were able to get all of our testing done. But if testing had been, in essence, about 100% of what it had been the year before, we would not have been able to get all of that done. And the most important part, particularly as it comes to HPV and sexually transmitted infections, is that we now know a lot of the same behavior that led to sexually transmitted infections continued during that part of the pandemic. We just simply weren't making the diagnoses anymore. We saw significant decreases, again, in doctor visits during that time, particularly in the year 2020, and we saw significant decreases in HPV vaccinations throughout that time. So as we, I had sort of already mentioned, right, how we impact HPV, our best tool probably is the vaccination. And we saw vaccinations really significantly decline in the year 2020, and we need to catch up with that. But during that time, there's probably plenty of unvaccinated people who probably acquired HPV infections. And again, we won't be able to just give them the vaccination to eradicate that infection. Once they have that infection, it's potentially long-term infections in at least some portion of those patients. As I mentioned, we had a consumable problem, meaning that we didn't have the things we needed to do to test for sexually transmitted infections. That's something that was a trend all across the United States, and in particular when it comes to sexually transmitted infections. Those were greater than for a lot of other tests that are out there. And if we just track it basically month over month, all of our testing consumables. While we've made it back to baseline now, particularly in the year 2022, we can basically get what we need thanks to the manufacturing of a lot of the companies. During the year 2020, there were severe shortages of a lot of things necessary to conduct all of our testing, including sexually transmitted infections, and particularly HPV. So there were a lot of people who have been impacted by the SARS-CoV-2 pandemic. And really, we've seen it overall all across the country. It doesn't matter what part of the country you're in, that has been impacted significantly. The one thing that we may not pay nearly as much attention to is that not every region or every part of the country is affected equally. And myself at a large academic institution, we were able to continue our testing throughout most of the pandemic. Our institution was able to continue to provide vaccinations, even though demand was lower during that time. But a lot of minority, particularly underserved communities and rural communities that don't have large hospitals that were able to access testing supplies that they needed, unfortunately may have gotten the short end of the stick during the pandemic. And that's something that it probably will take us a little while to sort of dig ourselves out from. So just in conclusion, HPV testing can be a critical part of our diagnostics to reduce cervical and other types of cancers. We know that testing dropped significantly due to the pandemic in 2022. The large part of that was that testing supplies were also diminished in 2020 as well. And accompanying the fact that testing dropped, testing supplies dropped, it was also the decreased demand for HPV vaccinations along that same time course. And there certainly is the potential that the lack of testing, the lack of vaccinations, is probably going to lead to more chronic HPV infections and the potential for an increased in HPV-related cancers in the years to come. So thank you so much for attending today. I really appreciate everyone that came to hear us talk a little bit about HPV testing. So now I'll turn it back over. Thank you.
Thank you, Dr. Pride and Dr. Calo, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. All right, let's get started. Our first question asks, have you seen an increase in HPV vaccination rates, screening rates in 2022?
Hello, this is William. Can you hear me?
Yes, I can.
Yeah. The data for 2021 in terms of HPV vaccination and other adolescent vaccines, it is expected to be released very soon. It usually lasts like a full year. So we will have information about state, regional, and national data hopefully very soon in terms of 2021. In terms of 2022, this year, I can tell you the own experience of our institution, Penn State College of Medicine and Penn State Health. We're seeing an increase in wellness visits as schools are resuming in-person education and people are more comfortable going to doctor offices. So we're seeing an increase in wellness visits. I don't have information about it. If that translates to more vaccines given during those visits, but at least we're having more kids coming to our own offices.
Great, thank you. Next question here asks, should we test the oropharynx of women with high-risk HPV cervical infections? How about their partner's oropharynx or urethra and semen?
So I'm happy to take that question. You know, in general, right now we don't have routine screening recommendations for example, for the oropharynx. And many of the tests for HPV that are available, in fact, are not validated for use in the oropharynx. However, there are many institutions really across the country that are validating their tests to be used to make HPV diagnoses from both the oropharynx as well as from the anal rectal areas as well. And I think that that's going to be a continued trend, so that something like screening of the oropharynx or even the anal areas will in fact be possible. Most of what we're targeting in terms of that sort of screening tend to be relatively high-risk people, and of course anyone that is symptomatic. But I do think over the course of maybe the next 5 to 10 years, we'll start to see more of that take place.
Great, thank you, Dr. Pride. Next question here. For adults who missed childhood vaccination, can they be vaccinated and how many doses?
The answer is yes, and they would require 3 doses. The most important thing is that for those up to age 26, they can go and get the vaccine in their primary care office. But if they are between the ages of 27 to 45, they have to have a conversation with their doctor to better understand if it's beneficial for them to get the vaccine. So the vaccine can be received, but depending on the age, it is recommended. But for some of those adults between ages 27 to 45, they would need to have a conversation first.
Great, thank you. Looks like we have time for a few more questions here. Next one asks, if a male does not present warts, is there a way to test, or excuse me, is there a test to determine if he is infected with HPV?
Yeah. And unfortunately, that's really a fairly complicated question to ask or to answer. And part of the reason is that we don't, for example, have great antibody tests for HPV. And the reason is that there are so many different types of HPV that it's very, very difficult to develop an antibody test to, for example, to determine have you been exposed or do you, for example, currently have HPV. What we do in particular for certain of our male populations is that we do in fact screen them, both their oropharyngeal as well as their anorectal areas for the presence of HPV. And we do that based on certain patient behaviors. With testing individuals, for example, who don't have warts is a bit difficult because the question becomes, well, what do you screen? So a healthy female, it's kind of obvious, right? You screen the cervical area. In a male, there's no sort of great analog for the cervical area. So the question is, can you swab the penis? We tend not to because it tends to be very, very uncomfortable. And the question becomes, well, can we at some point in the future screen urine? We're certainly not there yet in terms of screening urine for males, but that might be a sample type that we might think about that could be possible at some point in the future, but it's not something that's available and certainly not widely right now.
Great. Thank you, Dr. Pride. Looks like we have time for one more question here. And Dr. Calo, this is directed towards you. This asks, do you think that the COVID vaccination hesitancy has led to HPV vaccine hesitancy?
Yeah, and I'll say that vaccine hesitancy it evolved over time, but I want to connect two of those vaccines. I'll do these two issues, HPV and COVID-19. Some of the stories that we know are misinformation, especially in the topic of HPV vaccination, is infertility. That many parents believe that if they get the vaccine, their one of the side effects will be future infertility. If you look at one of the primary misconceptions about COVID-19 is exactly that one. Okay, especially among pregnant and postpartum women. And I'm working with some of them right now, understanding also their stories, filming their stories in order to educate their peers about why they should get the COVID-19 vaccine. So what we're seeing is a lot of the same misinformation has been replicated for COVID-19. Most of the misinformation for HPV has been replicated or expanded also to COVID-19 vaccination and vice versa. So I think it's going to be a little bit difficult to disentangle misinformation for both vaccines or for any other vaccines moving forward. The most important thing is to develop interventions that help us, to talk with parents and families in the clinical setting, as I mentioned also in my presentation, occupy those spaces. For example, in social media, we should be more proactive identifying misinformation, providing accurate information, or correcting that misinformation. So I think there's a lot of things that we can that we can do that can serve for both vaccines, COVID-19 and HPV, and it can serve for more of the overall vaccine hesitancy that we're seeing right now.
Great. Well, thank you again, Dr. Pride and Dr. Calo, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Roche, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.